Good afternoon, everybody. Once again, I'm happy to be speaking here. Brazil was a country that had breast as a specialty well before the U.S., and so it's always an honor and a special treat for me to come talk. My mission here clearly is to keep you awake right after lunch. Let's get right to it. We know that local control and survival in breast cancer are related, but that the relationship is dependent on the reduction in local recurrence being greater than 10%. And when we strategize for management of the axilla, we think in terms of what the local recurrence will be with this or that strategy. When the difference in local recurrence is less than 10%, no effect on survival at 15 years. We know that sentinel node biopsy works. We have many observational studies of sentinel node with a backup axillary dissection showing good accuracy and about 7% false negative rate. And we have now 7 randomized trials which show similar performance characteristics. About 2/3 of the time, the sentinel node is the only positive node. We know that false negative sentinel nodes do not turn into axillary local recurrences. We have 48 series in the literature following sentinel node negative patients with less than 1% local recurrence. The randomized trials have shown the same, both the Varanasi trial and the much larger B32 trial. Local recurrence does not develop from false negative sentinel nodes. We've been asking for a long time whether all sentinel node positive patients need an axillary dissection. There's a large literature looking at the prediction of non-sentinel node status in sentinel node positive patients, and the variables which predict non-sentinel node involvement are those which predict sentinel node involvement, in addition to a whole group of variables related to the metastasis itself in the sentinel node. And we have nomograms. My colleague Kim Van Zee is the author of the MSKCC nomogram, which you're familiar with. And here we have a nice comparison of 9 different models for predicting non-sentinel node status, and they're all pretty good. So between 2 randomly selected patients, one of whom is positive in the non-sentinel nodes, these models guess correctly about 3/4 of the time. Well before the Z11 trial, there's been a trend away from axillary dissection in sentinel node positive patients. And this is a nice study from the National Cancer Database of 400,000 patients. Of those with sentinel node macrometastases, 23% did not have an axillary dissection, and of those with micrometastases, half did not have an axillary dissection. So we were moving away from axillary dissection in these patients well before the Z11 trial. And here you see it plotted over time. Patients with macrometastases, the yellow line, about 20% not having dissection. In the micrometastases, an increasing trend toward no axillary dissection. And if you look at the outcomes in these patients, at 5 years, there does not seem to be any difference between those who had the axillary dissection or not. Whether they had micrometastases or macrometastases, axillary local recurrence was 1% or less. Now, this is a retrospective study, so it doesn't carry the weight of a prospective design. This is the entire literature on sentinel node micrometastasis, no axillary dissection. And what you see here is an axillary local recurrence rate of 0.3%. Highly selected patients, but a very low local recurrence rate. And we now have a randomized trial addressing this same issue. This is Viviana Galimberti's study from Europe. Sentinel node micrometastasis, no axillary dissection, and at a median follow-up of 5 years, no differences between the 2 arms of the study. Regional node recurrence, 1% in the no axillary dissection group, 0.2% in the axillary dissection group, and no difference in any other outcome measure. This is a forest plot. One of the groups of patients we're interested in are the mastectomy patients who were node positive and did not have an axillary dissection because they didn't get radiation. And as you can see from the width of the bar on the forest plot, this study was not able to answer the question for mastectomy patients. This is the literature on sentinel node macrometastasis and no axillary dissection. Again, a selected group of patients, but again, you see a very low rate of axillary local recurrence. Clearly, it's feasible to not do axillary dissection in selected patients with sentinel node macrometastases, and we have a randomized trial to answer that question, Z11, which you're all familiar with. This was a randomization of patients with 1 or 2 H&E positive sentinel nodes to axillary dissection versus not. These patients all had breast conservation with whole breast radiation. And patients with bad axillary disease, matting of the nodes, or more than 2 nodes were excluded. These are those selection criteria. They were well balanced in the use of chemo and hormonal therapy between the 2 arms. And what you see here is no difference in the rate of local, regional, or local plus regional events at 6 years follow-up. One of the most interesting findings in Z11 is that among those patients who had axillary dissection, 27% were positive. So presumably 27% of the no axillary dissection patients had positive nodes left behind, and yet these did not turn into regional node recurrences. And there was no effect on survival, no difference between the 2 arms of this study. This study was criticized because it did not reach its original accrual goal of 1,800 patients. It had a little over 800 patients, but it did reach statistical significance with that number of patients. And this has really changed our own practice at Memorial. More than 2 years ago, we switched to a policy in which patients who met the Z11 entry criteria did not have axillary dissection. And this is data we just presented at the SSO of our prospective study. And what we found is that 84% of patients who were Z11 eligible avoided axillary dissection. So for those of you who have not embraced Z11, and I know a lot of you have not, I would strongly encourage you to do so. This has been a real game changer for us, and we think it's been a significant benefit for our patients. Can we extend the Z11 entry criteria more broadly? Is there a group of patients outside the Z11 criteria that can also avoid axillary dissection? What about mastectomy patients who aren't going to be getting radiation? What about partial breast radiation? And what about patients who've had neoadjuvant chemotherapy? Well, let's talk about Z11 for mastectomy. Going back to the B04 trial, which had no systemic therapy 30 years ago, in the radical mastectomy node negative patients, there was a 4% regional node recurrence rate, and in the node positives, it was 8%. This is quite a bit higher than we're likely to see today. As you know, compared to other methods of managing the node negative and node positive patients, there were no survival differences at 25 years. We have a lot more data on no axillary treatment. In B04, as you remember, 19% of patients who didn't have an axillary dissection relapsed in the axilla. This is about half of the number that were node positive. We have many more recent studies, randomized and cohort studies, showing very low rates of axillary local recurrence in patients who had no axillary surgery at all. Selected earlier stage patients, but very low rates of local recurrence. Coming back to our National Cancer Database study that I showed you earlier, 15% of the sentinel node positive no axillary dissection patients had a mastectomy and did not have radiation as part of their mastectomy. We don't know the local recurrence rate in that group, but we know that in that entire study, there was a less than 1% rate of axillary local recurrence in the sentinel node positive no axillary dissection patients. If you put all of those local recurrences among the 15% who had a mastectomy, then you'd have a 6% axillary local recurrence rate. Obviously, that's not true, so one would estimate that the axillary local recurrence rate in that group of patients is probably in the range of 1 to 2%. We've recently looked at our mastectomy and breast conservation patients who were sentinel node positive and did not have axillary dissection, and this is a growing number in our practice, as you can see here. This is work of my colleague, radiation oncologist Alice Ho. We had a 5-year follow-up on these patients, and we wanted to see what had happened. Here you see a comparison between the mastectomy and the breast conservation patients. And I think what you can see right off the bat is more than half of these patients had immunohistochemically positive axilla, i.e. low volume axillary disease. About a third had micrometastases, and there were very few macrometastases. These patients had nomogram scores that were quite low, so the predicted rate of residual disease was low, clearly a highly selected group. And if you look at the 5-year follow-up, we really see no difference in the rate of local failure or regional node failure. If you take out the patients who had immunohistochemically positive nodes, and now you're focusing on patients with micro or macro metastases, you do see a small trend at 5 years toward more regional node failure in the mastectomy patients, about 5% versus about 2%. But I think what you also see along the baseline here is very small numbers of patients. So we would like to see these data replicated on a wider basis, but we're not seeing high rates of axillary failure in this group of patients. What about Z11 for partial breast radiation? When you don't radiate the whole breast, you don't have that overlap of the axilla that we all know about. The issues with partial breast are simply that if you're not accidentally radiating the axilla, will the results be as good as when you accidentally radiate the axilla with whole breast radiation? The problem is that partial breast radiation studies are usually limited to node-negative breast cancer. So we simply don't have the data on patients with node-positive disease. Here are the 2 trials I think you need to know about. The Mammocyte registry is just that, a registry of patients who had mammocyte balloon partial breast radiation. These patients' results were quite good. The axillary local recurrence rate was less than 1% at 5 years follow-up. We have a prospective randomized trial, the Target trial. Here, there was a small group of node-positive patients. Again, a very low rate of axillary local recurrence. So we don't have enough data for partial breast to really answer the question that we're asking. What about neoadjuvant chemotherapy? We know that there's no difference in survival between chemotherapy up front versus chemotherapy after surgery. We do know that neoadjuvant gives you a higher rate of breast conservation, but largely for patients with the T3 and T2 tumors, not the smaller tumors. And we know that neoadjuvant downstages the axilla. About a third of node-positive patients become node-negative. And with current generation chemotherapy protocols, it's actually about 40% of node-positive becoming node-negative. If this is the case, can we avoid axillary dissection in subsets of these patients? There is a literature looking at sentinel node biopsy done after neoadjuvant chemotherapy, 27 small studies, the success rate a little less than one would expect, but the false negative rate about 10%, acceptable. Looking back at those studies, among the patients who were node positive, it also appears that the false negative rate, 11%, is acceptable. So even among patients who appeared to be node positive up front, this may be feasible. Some of the largest studies we have are the NSABP, and here you see a comparable false negative rate whether the chemotherapy was prior to sentinel node or after the sentinel node. And we now have a prospective study, ACOSOG 1071, in which patients with proven node-positive disease all had neoadjuvant chemotherapy, then sentinel node with a backup axillary dissection. The success rate was a little over 90%. The false negative rate was 12.6%. The false negatives were more frequent if you only removed one sentinel node and if you used single agent mapping. So the take-home point here is when you're doing sentinel node in a setting where you expect it to be more difficult, technique matters. Use two agents and take more than one sentinel node. We have another study, a German study, in which the authors, if you were clinically node negative and the sentinel node was negative, you had no further surgery. If your sentinel node was positive, you had chemotherapy and then a second sentinel node biopsy with an axillary dissection after the chemotherapy. If you were node positive up front and converted to node negative, you had a sentinel node with a backup dissection, and if you remained node positive, you had axillary dissection. Now that's a mouthful, but here's what they found. If you had a sentinel node up front, the success rate was 99%. This is what we would expect. If you did the sentinel node up front and then did it again after the chemotherapy, the success rate was dismal and the false negative rate was quite high. So I think the message here is that if you're doing sentinel node in the setting of neoadjuvant chemotherapy, do it once and do it after the neoadjuvant. And here you see their success rate in that group of patients was 80%, a little less than optimum, but the false negative rate was 14%, which is in the range of what we've seen before. So sentinel node does appear to work in node positive patients after neoadjuvant. I think we'll skip that. We have a next generation of clinical trials to address the neoadjuvant issue. For patients who are node positive prior to chemo and become sentinel node negative post-chemo, a randomization between radiation to the nodes versus no radiation. For patients that are sentinel node positive, that are node positive pre-chemo and are sentinel node positive post-chemo, a randomization to axillary dissection versus no axillary dissection. These trials are not yet up and running, but they're proposed, and I think this is our next generation of working out how to manage the axilla in the setting of neoadjuvant chemo. And this is just the schema for those trials, very simple. So my conclusions for this part are that sentinel node positive no axillary dissection is feasible for selected low-risk patients outside the Z11 criteria. The present evidence for mastectomy and partial breast irradiation, I think, is insufficient. We have low event rates, but we have very little data. I think the evidence for sentinel node biopsy after neoadjuvant chemotherapy is sufficient. The success rate is somewhat lower, false negative rate is comparable, and technique matters. Take more than one node and use two methods. So randomized trials of Z11 for neoadjuvant are ready, but the question is, are we? I want to finish up by showing you Emil Rutger's Amoros data. This was just presented at ASCO, and I thought you'd want to hear about it. This, as you know, is a European trial in which patients with positive sentinel nodes were randomized to axillary dissection versus axillary radiation. and if you were sentinel node negative, you were just followed. Very good quality control on the axillary radiation, good quality control on the axillary dissection, 18 nodes removed. Here's what they observed. No difference in the rate of axillary local recurrence. A little over 1% in the axillary radiation group, 0.4% in the axillary dissection group. Not significantly different. And basically the same axillary recurrence rate in the patients who were sentinel node negative and were just observed. The rate of lymphedema, based on clinical observation, was significantly less in the patients who had axillary radiation. And this, to my knowledge, is the first really good head-to-head comparison we have of the morbidity of axillary radiation versus axillary surgery. It's less with radiation. And lymphedema, as actually measured in the arm, you see the same difference. These are patients who actually required treatment for their lymphedema. They needed treatment a lot less often if they had radiation. Shoulder function was a little bit worse in the axillary radiation group, but this was only in the first year. And quality of life was not really different between the two groups, although there were some trends toward more difficulties with the arm and more arm swelling. So my final conclusions. Sentinel node biopsy is well established, but next generation trials in clinically node negative cancer are going to compare sentinel node with no axillary staging. Next generation trials of clinically node positive breast cancer are going to be comparing combinations of axillary dissection and radiation. Axillary dissection remains an option for us, but increasingly we're going to be doing this for the treatment of gross axillary disease and for the treatment of axillary recurrence, which I think is a more and more infrequent event. For sentinel node positive patients, axillary radiation is equivalent to axillary dissection and local regional control with fewer side effects and better quality of life. This is something we really have to think about. Thank you very much.